talking 10 minutes. I would like just to present briefly, and then I will be very happy if you give me feedback of my coming research. So I'm interested in I have been working with migrant workers 10 years, different topics, social representations, education, and now I'm going direct to sexual practices and emotional practices. So I'm interested in, I would like to know, in this seasonal agricultural worker program, in this program that the migrants go and back, how the sexual and how the emotional practices change because of this context. As you know, they come for 8 months to Canada to work here. And then what happened with their emotions and what happened with their sexual life? I mean, they come and they don't leave their sexuality over there. They bring it with them, of course. So I would like to know what do they with that, you know. Okay, so I would like to know how did this social and cultural historical context shape migrant sex lives in both an emotional and physical manner, and how does working in Canada allow migrants to really find this emotional and physical connection in their everyday lives, and how this temporary nature of the seasonal agricultural workers program impact the sexual and emotional health of migrants and their partners who remain in the communities of origin. Already, there's some literature that in Canada, but it's not enough to explain of these complex issues. Janet has been working in that. Kerry used to work in that field in Simcoe, but we need to explore more because it's very complex issue. What are the contextual risk factors faced by male and female migrant workers during the migration process? Is there a correlation between the gender of the migrants and risk sexual behavior? What patterns of STIs exposure exist among migrant workers and their partners both in Canada and in Mexico? What mechanisms are migrants, Canadian residents, and institutions using to protect and promote sexual health and family relations among workers? So as you can see, this is a very complex issue because I have to do field work in Mexico with their families, their wives of migrants, and I have to do also field work here. So I already start my field work in Mexico, and I decide to do by interviews, deep interviews. I would like to apply also a service in some of the communities here in Canada. So just to give an example, as you probably know, one of the required to be part of the swap is that they have to be married. Because this is a kind of a control. They don't want that they stay here. So the most of them are married. Well, the most of them has like a long contract for more than 6 months. Well, they have been working in Ontario for more than 10 years, like 4,803 workers. Okay, the communities where I'm focused in Mexico are Huijingo, that is the highest number that the participation in Ontario, it's Estado de Mexico. Also, I choose another one that's a rural community, is Los Del Montes, and the third one is in Morelos. So these are the 3 communities that I have been working in Mexico. Well, some more information about that communities. For many years, Huijingo is the toughest rural community that is part of the program. Okay, well, some photograph. This is another one that's Guanajuato also have very high tradition of participation in H2A in USA, not just in Canada, also in USA. Okay, well, this is the other one. Okay, so where they arrive. So now I'm working with Janet to decide what are the communities where I will do my field work in Canada. So the most participation of Mexican in Ontario is Leamington, and then, well, you can see, so we are thinking, we are talking about this. I have a amount to do field work, but not enough. So I would like to decide which are the communities. I'm thinking doing in Niagara, well, in St. Catharines, and also in Simcoe.
Hi everyone, I'm Raquel Bremer. I'm from the AIDS Committee of Windsor, and
I'm Dane.
the AIDS Committee of Durham. So we're going to talk about what we do in our individual communities, and we're going to focus on sexual health relating to migrant farm workers. We belong to a strategy called ACHO, the African Caribbean Council on HIV and AIDS in Ontario. There are 13 of us spread out across Ontario, and we're 2 of them. So we reach out to the African Caribbean Black communities where HIV is a risk factor. We work with persons who are infected with HIV, who need education around HIV from the ACB community. And I'll be saying ACB, African Caribbean Black, for short. So we do a lot of knowledge translation through workshops, presentations like this. So the strategy's been around for about 10 years in Ontario, and we focus on Ontario because about roughly about 25% now of new infections of HIV are persons from the African Caribbean and Black community in this province, yet we represent like 4% of the population. So we're 1 in 4, and we're very small in population. So this strategy came about because of that issue, and it's still a very big issue. So the objective is to reduce the rate of HIV and other STIs, but we focus on HIV. We are housed in AIDS service organizations, and we provide support, care, raise awareness, advocate, do lots of partnerships with clinicians. We put on forums. Last year, for example, we put on a forum in Windsor focusing on medical professionals. So we had about 81 doctors and nurses come out on our Saturday at Caesars Windsor for the whole day to talk about HIV. And we had epidemiologists and OBGYNs and the leaders in HIV in Toronto, London, focusing on the work that they do at their hospitals in collaboration with the HIV care program at the Windsor Regional Hospital. It was very, very successful. What we found from that was that a lot of frontline clinicians, RNs mostly, said they never really work with HIV because we have the HIV care program, which is just a handful of clinicians working in a hospital, and nobody else really deals with HIV. So they're sent there. So how do you learn about that? So that's where we try to step in. Dane, you've done a lot of work in Durham, working with different populations as well.
Sure. So the work that we do in Durham is quite similar to the work Raquel does in Windsor. We work with very similar populations, African Caribbean Black communities, kind of unique to Durham region and our organization. AIDS Committee of Durham region is very much social justice focused, so we tend to break a lot of rules, not intentionally, it's just what we need to do, it's how we need to do things. So with our information and with our details in relation to the strategy, just what Raquel was mentioning with the statistics, in my work in Durham region, just looking at just the optics and the feet on the ground, what we're seeing is that Black communities in Durham region are very much spaced out. So there may be a pocket here, a pocket there, but there's also a mixing of communities, so an intermixing of communities, primarily biracial. So it would be Black partners with white partners and so on and so forth, what that does, that actually inflates or skews some of the numbers that are coming out. In Durham region, one of the stats, at least we can say in Durham region, but from those who are familiar with LINs, local health networks, we're getting new statistics in Central East. The infection rates among black women, young black women, going on an upward trend, and women over 40. Women over 40 in Durham region is a widespread, so that includes white women as well. That just goes back to the intermingling of our community.
So we have 5 minutes left, so I'm going to speed up a bit. So these are the main issues, and I looked at the research study that's done by Janet McLaughlin, who will be doing the talk this afternoon, and these are some of the things that we've already raised. Lack of independence. We have employers going into emergency rooms and walk-in clinics speaking on behalf of the migrant workers and miscommunicating really the incidences and lying and reporting the issue to the liaison officers of the countries, and they're generally sent home if they're injured. So we've actually had cases where even if we wanted to help, we can't because the clients disappear. There's no follow-up, there's no care. So we're working very closely with the health unit and the community health center in Leamington, and Cindy and Danielle are here, become BFFs, because of these issues. Racism, stigma, and discrimination, Chris, you mentioned, that's huge. And we are population specific for that particular reason, because the rates are high in our population. There's homophobia, there's poverty, there's lack of awareness, there's literacy issues. There's so many of these issues that we have to deal with and take into consideration when we do our work. And they can't be ignored because they cause serious issues. I'm going to skip this. That's just an example of some of the racism that we've seen. If you Google migrant workers Leamington, you'll see a lot of negative perceptions that are perpetuated in the community that cause barrier in even working with the community. They are like, oh, they're sexual predators, we're afraid of them, they're the ones spreading all this sexual transmitted infections, they're doing all of these things and they're not integrating. So there's that fear, and it's not a good issue. So what we do monthly resource distribution, including harm reduction. Dean's going to touch on that. So we go out to the bunkhouses. We actually do events. We give out condoms. We do one-on-one discussions. We have health fairs with a lot of the stakeholders in the room. We do ongoing presentations. We work with service providers to talk about culture, to talk about racism, to talk about how we can work together, because we can't do it alone. I'm an AIDS service organization. Once you mention HIV, they're like, we don't have that issue, sorry. And they want to back away. But if you say, I'm a clinician, they're like, oh yeah, we can work together. So, and we do research. We're conducting a research study now with the University of Windsor, University of Toronto, researchers in London, looking at HIV prevalency and resiliency among African Caribbean black men, called We Speak. And it's a 5-year study. We got $500,000 to do it, so it's really to raise that awareness. And these are some pictures of some of the events. We work with a lot of the faith-based communities, so these events were done with a community partner called Joan Campbell in Leamington at the South Point Church. She puts on Mother's Day events, Father's Day events, Christmas parties, celebrations around the holidays. So we go out to football competitions at the parks, and Dane also does the same thing in Durham. You want to talk about the harm reduction
Okay,
piece?
so we got the card, but I'll be really quick. Harm reduction. So when the term harm reduction or risk reduction is used in communities, it's typically associated with illicit drug use. As mentioned, we kind of break some rules. So when we're going out with our materials, with our kits, so harm reduction does include condom distribution. It also includes pipe kits, so crack kits, needle kits and such, where the rules are kind of fudged. But in doing that fudging, we're working with other community agencies and health clinics we actually provide needles and supplies for diabetes or for other conditions, other co-infections that the workers may not know that they're able to access on their own whenever they need to, but are not sure exactly where to receive or where to obtain those materials, so such as receiving needles and receiving multiple needles. We're funded to distribute these kits. We bring them along because we're aware that there may be situations, real quick, they were talking about nutrition. Diabetes is one thing, insulin management, other co-infections. So just a simple thing as providing like alcohol swabs and short tip needles, for example, to take your treatment, your medication, it really goes a long way in doing this work in the community. And it's with Black community, but also with the Mexican communities, the Thai communities that we're actually seeing an uptick in the request for needle kits, pipe kits. And it's primarily just for their primary point of care, not necessarily for illicit drug use.
So this is an example of some of the condom dispensers that we have funding to put up. So these are put up at restaurants, barbershops, the universities, the pubs, the convenience stores in Leamington and Windsor and Chatham. So persons can just walk up to a wall, pull out the condom and go on their way after leaving the club. So it has the number of our AIDS service organization and the health unit, so if they want to get tested or if they need to replenish the stock, they know they can call. And this is just more about our strategy. Migrant workers are listed to focus on other issues, and we look at data to focus on where we need to be. In my area, Windsor, Essex, the blue represents Caribbean, the Caribbean population. In Durham, it's spread out. So we have over 25,000 in Ontario. The problem is they don't have access. They're working 80 hours a week. They're not able to access healthcare. So these are the strategies that we employ and the partnerships that we build. We're really trying to work with the health unit more to have our biannual health fairs to ensure that they have extended hours and that we just do case management together because it's really critical. And February 7th is the annual HIV awareness day. So we try to beef up activities around that day as well. And that is it. Thank you.
My name is Richard. I'm from the Asian Community AIDS Services.
And Fendi.
So Fendi has been a client of ours and also a volunteer at ACAS. That's the acronym of our organization, ACAS. But I don't have slides, so all attention to me. But pretty much, essentially, what we're going to talk about, similar to AIDS Durham and AIDS Windsor. We just changed the population, the Asian population, which can be Thai migrant farm workers, the Philippines, that one. And coming in, more influx coming in is the Indonesian farm workers. They just started doing their research while ours just finished. So we have the fact sheet. Yeah, I can distribute this. We didn't bring that many, so hopefully if you want a copy of this, I can forward it to your email and I can just send some more out. But having seen that presentation, isn't that funny that when we actually do workshops on sexual health, we have to mask it as community events? Because no one wants to talk about sex, really. Migrant farm workers don't have sex. Are you kidding me? Yeah, so I remember when we did the first outreach for migrant farm workers. This is back in 2009, and Chris Ramsbrough, we built a good relationship with their organization. So when we started doing this outreach, the Filipina migrant farm workers were there. And on one condition, this happened in a church in Leamington, is that right? I don't remember anymore now. But it's a health fair, the first health fair of migrant farm workers. And it's small, it's still growing, and I'm glad that it happened. one condition that they imposed on us was we're not allowed to hand out condoms inside the hall. We're allowed to hand out condoms outside. It was pissing down, pretty much like this. Me and my coworker, we went outside at the back. We thought we were going to be having a hard time handing out condoms, and these loops were just going to be standing there for hours. But as soon as we walked out, for some reason, the Mexican workers, they knew we were going to hand out condoms, and they just boom. 10 minutes, 100 condoms gone. So they're not having sex, of course. So yeah, so that I was impressed by that, I guess, reaction, like eagerness that they do have sex. So there is this market here to do more sexual health workshops. However, the strategy is to just coin it in a different way, that we have to talk about HIV in terms of good relationship with your partners, how to navigate in like accessing health. And I'm actually impressed that sexual health is included in this conference this year. Whereas I've never seen it before. This is my first time, but I've always seen the agenda. And it's just, I think it's too naive if we include faith communities in supporting migrant farm workers' access to health services, that we don't include sexual health in it. Because we address racism. You know, the oppression that we experience within the migrant farm workers is similar to the Black community. It's there. Power dynamics exist within employers and employees. And then within employees and other employees also exists. Within the Blacks and the Jamaicans, within the Mexicans and within the Asian farm workers. I think we cannot dismiss that. That plays a strong interaction, I suppose, and that's where all this health talk can happen, by addressing that as well. So how much do I have?
You're good.
Is it? Okay, good. So yeah.
You're right at 5 minutes.
Yeah, and I think our agency is also lucky when we have a Thai community, established Thai community within this region, and that's where we build the relationship with them. We'll build allyship, and they're willing to accommodate us to be part of that health fair. And we are also in a good position with another agency in Toronto. It's called Hassle-Free Clinic. And from time to time, we're able to lure them, hey, come to health fair, you're gonna do a lot of HIV testing. You're gonna get a lot of numbers, which is good for them too, because at the end of the day, it's about numbers that they produce. Oh, I've done 10 tests today. And just last summer, there was a health fair held in Toronto, and we got a huge number of people. The Thai migrant farm workers showed up, and that was a very good opportunity for us to again invite Hassle-Free Clinic to do the anonymous confidential HIV test. It was just a simple setup. It's a tent, and we have our volunteer and our staff there in Next as well. So they man the clinic per se, take the names and just have them, get tested. So I think it's important to build informal networks. Like Dane said before, a lot of rules we kind of navigate, bend it a little bit, find loopholes within that. And that's, I think, how we can work together among agencies, stakeholders, and sometimes funders, they're not all that bad. Sometimes they are willing to work with us. Yeah. So I think to address that research earlier, it's very ambitious research, by the way. Good luck. And to talk about family, we've seen how family disintegrates from when they arrive from there and then come here, because that relationship change as well especially between men and husband and wife over there, and they build another relationship here just to compensate that. I think as human, no matter where we are, we're thirsty for that connection. Yeah. So we've seen that in the past as well. The family structures disintegrate. And lastly, so far we haven't found available epi data for HIV for migrant workers. So I don't know if you guys have any source available. It's never been done, so we cannot know for sure how many migrant farm workers are infected. I can just base it based on our men who have sex with men numbers, which is 1 in 4, if we can go with that number. So I'd like to introduce Fendi to just talk about his experience.
Okay. Good morning, everyone. Buenos días, amigo. Poquito speak Spanish because my friend in the farm from Mexican. My name is Fendi. I identify as a Cayman with PhD. The first I want to say English is second language for me, and I apologize if there is a mistake for say something. I come to Canada on July 2012. I was on temporary worker contract for 2 years. I work in farm in Leamington, Ontario. Many people say, "Are you kidding me? Are you working in the farm?" Because looking my fashion, yeah, but it's true. I work in the farm. Yeah, because I'm human. It's normally I need looking sex. Yeah, I have the case of sex over there. And then in September 2013, I was diagnosed with HIV positive. I was hospitalized for 4 months in Toronto East General Hospital, and then 1 month in the Casey House. Since the time I became acquainted with ACAS, Asian Community Aid Service. During hospital treatment, Team ACAS specialist Richard always visit me in hospital for the support and educated about HIV.
Because we come from the same country, actually, so I didn't only act as an educator. It's a dual roles for a lot of us. Many roles, yeah, multiple roles, yeah.
After 1 month in the Casey House, I had to come back in the Leamington for the working again because my work permit expired, but I always contact with ACAS, and then I need ACAS help me, and then I decided moved to Toronto for the support my condition, because in the meantime I never to meet a provider or organization for help me. Very difficult over there because I feel lonely over there. And then I moved over there in Toronto. ACAS helped me for the apply anything about my status for the apply refugee and then permanent resident, and then apply Ontario work or ODSP, and then apply housing connection. Yeah, I'm lucky I got anything. yeah, my status permanent resident now. And then, thank you so much. And then my activity, I always join in the ACAS for the volunteer, for the help people around me. I have benefit for the people around me and my condition, situation. I feel happy, and then I join in the 5 house. Maybe the people know about 5 house. I join over there for the volunteer. Yeah, I'm happy. And then always for my life now, always thinking positive, exercise daily, volunteer freely, worry less, and about eat healthy, love always, sex safe, and then life forever. Thank you so much.